Yes,
Yes,
ma'am.
ma'am.
Yes,
Yes, there
ma'am.
will be a 2 minutes. Okay. So now, uh, so again, welcome to all postgraduate students. Welcome. And today's topic in JHOS PG webinar is post-op endophthalmitis. And the speaker is Dr. Archana Kumari. She is a very senior vitreoretina surgeon from Prasad Eye Hospital, Ramgarh and Manipal Hospital, Ranchi. So she will be talking on post-op endophthalmitis. So over to Dr. Archana.
Yes, thank you, ma'am. Thank you so much. A very special thanks to CSC Bharti Kashyap, ma'am, for giving me this opportunity in the JHOS platform. And so we'll discuss today the topic post-op endophthalmitis, which is a very important topic for all of us being students, for exams, being clinicians, for our day-to-day practice. So, what is post-op endophthalmitis? Post-op endophthalmitis is inflammation of. Did I do the slideshow so that I think? Yeah. So, post-op endophthalmitis is an inflammatory condition of the eye, which is presumed due to infectious process. It may be bacteria, fungi, or parasites, and they enter the eye during the perioperative period. Matlab, it may be just it's not always during post-op period only. It can be even intra-op period or just pre-op. So it is of two types. I get either acute, which is within 6 weeks, or chronic, that is delayed onset post-op endophthalmitis, that is after 6 weeks. So anything which is within 6 weeks is acute, and these acute is again divided into fulminant, which is within 4 days, and this is really very difficult to manage here because salvaging vision is not the talk here. The talk is to salvage the eye and the salvage the life of the patient, because this is really fulminant and tends to spread with causing panophthalmitis and even orbital cellulitis. Next is acute, which is within 4 to 12 days, and subacute, which is from 12 days to 6 weeks. So the pathophysiology is incubation period. Incubation period is when it is in the eye, it is very subclinical, there is no symptoms. The eye is trying to control the infection, okay? But in the acceleration period, many eyes will enter straight in the acceleration period if there is implantation of organisms in the posterior segment. Or incubation period, if it is in the anterior segment, will be, with time, there is inflammation and breach of the this aqueous barrier, and then in the acceleration period, it causes multiplication of the bacteria. There is phagocytosis, phagocytes come in, the opsonization happens. But if clinical features start coming in this phase, but here if we do usually this is the phase when culture is negative, because most of the organisms are attacked. It is in the macrophage, it is being opsonized, it is being attacked. But the destructive period is the phase when there is abundant of multiplication of the organisms. Already there is insult to the retina, vitreous, the growth in the vitreous starts. So what is the incidence? Incidence of post-op endophthalmitis, if we only talk about post-cataract endophthalmitis, is about 0.02% to 0.26% in India, but the culture positive is even less. It is up to 0.09%. So the microbial spectrum is mostly it is Staph aureus. Okay, so it is mostly it can be coagulase negative staph as a broad, if we say, okay, and Staph aureus. This one I wanted to keep because this is very important for practical purpose. Gram positive organisms are common. Okay, in India it is up to 53.1%, but gram negative organism, which otherwise in other parts of the world is very less, is very high in India. In few studies, they have said it to be about 42% and few 26.2%. So we have to be always very wary of it. And even fungal endophthalmitis is high in India and China. So what are the risk factors? Risk factors of post-op endophthalmitis can be either ocular or surgical. Ocular is because of ocular flora. That may be just because there was this blocked nasolacrimal duct, because of which there was organisms, or the normal flora of the eye had an access into the wound, or blepharitis. And surgical is instruments, it's not properly sterilized, or wound healing is not there, or proper wound construction is not there, which leads to proper wound healing, and surgical complications obviously increase the chances of post-op endophthalmitis. Now, the risk factors can be preoperative, intraoperative, or post. Preoperative, diabetes mellitus, immunocompromised status, and again, what we talked about, blepharitis or lacrimal passage blockage, contaminated eye drops, contact lens wear. But intra-op, now to we don't use it, but it was found that use of xylocaine gel before povidone iodine, because povidone iodine is something which has been found to be really limiting, decreases the rate of endophthalmitis. So if we put a xylocaine gel before it, then it makes a nidus. Okay, so prolonged surgery, secondary IOL, PCR, vitreous loss are all risk factors. Post-operative wound leakage or vitreous incarceration are the risk factors. So ESCRS actually found this. I wanted to, for practical purpose, all of us to know that a well-controlled diabetic and non-diabetic, there is no evidence of any difference in endophthalmitis rate in them. And similarly, equipments, disposable or reusable, they have not found any quite evidence of it. Now, intracameral ESCR has found that intracameral cefuroxime really limits the occurrence of post-op endophthalmitis. Okay. Now, let's come again to time of presentation. It has been found that most of the cases they present till maximum of like up to 14 days. Okay, and there are only 22% of the cases were present after 14 days. So these are the pictures of, you can see fibrin membrane. These are my own clinical photographs of my OPD, my endop cases, which I managed, refer from other centers. So you can see there is, uh, here in second case, you can see this anterior segment is clear, but there is haze behind the IOL. And there is hypopyon in first case. Second case is a fungal one, and there was white, mm, mesh like just behind the IOL. And so it can be, one thing more we have in mind is that either it is infectious or inflammatory. Why we are talking about this is because inflammatory cases we'll talk about, TAS, is also something we should figure out earlier without intervention. So classification of endophthalmitis is, it can be infectious, non-infectious, even the post-op ones. For example, non-infectious can be if you see a hypopyon day one and there was lens-induced uveitis, means the lens particle were left behind and the patient had lens-induced uveitis. Mostly they don't present with hypopyon, but can. And second is, which I have not mentioned here, is complicated cataract, means post-uveitic cataract. Okay. So for infectious, we know it can be exogenous or endogenous, exogenous surgical or non-surgical. Surgical is what we are talking about. But we have to keep in mind that even surgical cases, it can be endogenous or non-infectious. Okay. So coming to TAS and infective endophthalmitis. So TAS is like that what I was talking, that it is inflammatory or it is infective. Even now we talk about toxic posterior segment syndrome, but for clinical practice, TAS and endo, even for exams, you will have to differentiate between them. In TAS, first post-op date can present infective, always later. In TAS, always pain and lid edema, it's less uncommon. Congestion is very less, conjunctival congestion, but corneal edema is remarkable. It is limbus to limbus, unlike infective, where it's just patchy. Iris is fixed and dilated, and intraocular pressure is raised in TAS. But in infective, there is variable. It may be raised or normal. And the TAS responds dramatically to topical steroid. Okay, so these are cases of TAS. Mostly we'll see that there is edema of the cornea and anterior segment reaction only. But all sterile is not toxic. This has to be kept in mind, especially when we see that there's more of cases of TAS appearing or toxic posterior segment syndrome. So these are few cases which came out to be TAS later on, but they appear so much just like infective endophthalmitis. So investigations is, random blood sugar is very, you have to do a battery of tests, preparing it for surgery also, but random blood sugar should be done because most of these patients are, the reason can be poor blood sugar control, which has led to endophthalmitis. Anterior segment photograph just for documentation. B scan to see how much vitreous is involved. Vitreous and aqueous tap is very important, okay, in these cases. Apart from a PCR, which may be needed. Okay. So the vitreous and aqueous tap, the gold standard is vitreous biopsy, which should be done by cutting the vitreous, because always whenever we do a vitreous tap, we pull it. Though that is what we are, mostly it is being done because people don't have access to vitreous biopsy, vitrectomy cutter. So, but it always has there is always chances of traction in the vitreous. So vitreous biopsy is the gold standard. So how to do aqueous tap or vitreous tap? Very simple. Uh, do it if, see, this one they have put a trocar and they are doing because they have a cutter in hand. But in general, we can just do it with a 1 ml syringe using a 26 gauge. We cannot do it usually with 30 gauge needle. And first, a proper exposure of the eye, proper sterility. No point, blocking the eye until unless it is, you think that the procedure will be long, and no need to block to give any kind of blocks. Just under topical anesthesia, we can just take a as in the second picture, an AC tap or a vitreous tap, followed by injection of intravitreal antibiotic. Uh, and it is very important to send this sample for gram stain and QH, because gram stain has of at least gives an idea and guides us of future management. Even though it's not in 100% of the case, you don't get gram stain positive. Okay, and aqueous tap even has lower percentage. So vitreous tap is mainly preferred. And at the same time, we have to do it, culture sensitivity we have to do. Now, the point is that culture sensitivity confirmed reports also we don't have in all the cases. Means any case, if it doesn't, no organisms grow in the lab. EVS study showed that only 69% of the cases there was growth in the lab of organisms. So अगर आपने किसी एंडोप का टैप लिया है and we have sent it for culture sensitivity, there is no gram stain negative, there's no gram stain of the any organisms. Gram slide is negative and there is no growth in the culture. Still, it can be endophthalmitis because it is culture positivity, but the lab, which is called lab confirmed growth. Lab confirmed growth is either you get it in gram stain KOH or in culture. So that is not 100%. It is maximum up to 69% reported till now. So now two things. So here comes in mind what presumed endophthalmitis and confirmed. So as we have talked, lab confirmed are confirmed endophthalmitis and presumed are clinically. So the management again is first of all to salvage life, especially in case of fulminant endophthalmitis because it may lead to septicemia, then salvage the eye. And last is obviously we do target safe vision. For if a case like this comes post-op day one, which is very rare, always mostly there is a lucid interval. So here salvaging life is the first priority. So there was a recommendation which was by EVS, endophthalmitis vitrectomy study, which said that intravitreal antibiotic, give it till hand movement vision. If it is worse, go for pars plana vitrectomy. But now the thing has changed. What we are talking about is complete and complete vitrectomy and early vitrectomy. Why we are talking about this? We are talking about complete and early vitrectomy in endophthalmitis because there is a saying. What is that saying? That saying is whenever there is pus, we have to remove it. Okay. So UB pus, EB evacuator. So gold standard is pars plana vitrectomy. If endophthalmitis is confirmed, pars plana vitrectomy should be done irrespective of the vision. Core vitrectomy is must. And obviously, there's advantage and disadvantage. Advantage is that you are deloading the vitreous, the infective material from the eye. The antibiotics will act better. And disadvantage is always any invasive procedure, vitrectomy, is associated with risk factors like it can cause RD, breaks, all that. The silver standard is that just give intravitreal antibiotic, Vanco Cefta, Vanco 1 go. Always remember, even so that in your dreams you remember it, Vanco 1 milligram per ml and ceftazidime 2.25 milligram. Okay, amikacin was earlier used, but because of its retinal toxicity, it's rarely used now. Now, adjunctives, always there is question, should steroids be used? So, intravitreal steroid should be limited if we know, especially fungal may flare. Topical, yes, we can use. Systemic, there are many studies we don't favor it, but if a patient is diabetic or there's other foci which is expected, uh, or in very acute cases, we should avoid steroids. So, and now IV antibiotics. So, EVS said that there is no role, but ESCRS said that if there is severe acute purulent post-op endophthalmitis, or there, we should give, and the intravenous antibiotic जो भी we are giving should be same as the intravitreal antibiotic that complements each other. Okay, and these are the antibiotics that is usually used. Now, the prophylaxis is always better than cure. So, what is a prophylaxis? I have talked in earlier slide also. ESCRS found that intracameral cefuroxime is very important to be given. A prophylaxis, always remember that the first one is that pre-op topical antibiotics. Again, all the studies have not proved, but few studies have proved. So, pre-op topical antibiotics should be given. Intracameral cefuroxime should be given. Again, many studies say that they may cause antibiotic resistance, but this is the only one. This and povidone iodine or aqueous chlorhexidine has been found to be really decreasing the rate of endophthalmitis. So, endophthalmitis can occur in best hands, in the best setups, but what really can help us or save the eye is timely diagnosis and management and referral. We should never shy away from that. Thank you. Any questions from the postgraduates and the optometrists?